Hi there, good afternoon. Thank you for joining me today. We're going to talk about lymphedema surgery. My name is Sue Jordan. I'm a plastic and reconstructive surgeon at Northwestern Medicine. And breast cancer-related lymphedema, cancer-related lymphedema is a topic that weighs heavily on a lot of folks' mind when they get that diagnosis. So there's a lot of new options out there for lymphedema. And I'd just love to kind of go through it with you today. So what is lymphedema? Lymphedema is swelling of the arm, swelling of the leg, often after a cancer diagnosis and lymph node surgery. The most common reason for lymphedema is breast cancer related. And it's just a side effect of all the necessary things that we have to do to get rid of that cancer. And I like to think of lymphedema as just a big sewage problem. So the lymphatic system is the sewer system of the body. All the fluid that is made when we're doing activity, when it's warm outside, that fluid has to be collected by the lymphatic channels in the lymphatic system. And those lymphatics drain all the fluid, and they have to carry that fluid up the lymphatic channels or the pipes up to the armpit where the lymph nodes live. And the lymph nodes are meant to screen all the fluid before it makes it back into the bloodstream. Obviously, when you take those lymph nodes away, all the plumbing gets backed up. And for a while, your lymphatic channels chug along and they're working really hard. They might get really full, and so they're at capacity. And even up to a year after mastectomy, radiation, any therapy that's necessary, they just, that's it. They've worked so hard and they can't keep up. And fluid starts to back up and, leak out into the tissues. And that's when people notice arm swelling. It could be something like the watch doesn't fit quite the way it used to, your rings don't fit the same way they used to, or it might just be this feeling of weird heaviness, just vague, maybe not painful, but definitely not what it used to be. Feel it in the arms, you can feel it in the chest wall, near the breast, and all of those are just early signs of lymphedema. For the longest time, the only thing that we had to offer lymphedema was physical therapy. They have really been, those physical therapists have been carrying the flag for us for decades. And so what does that mean? It means massage therapy to push the fluid and find an alternate way to drain the fluid. It means gloves and sleeves to keep the fluid from building up. And all sorts of compression regimens to just manage the plumbing. It's only been pretty recently that we've had some new surgical options to try to treat and even prevent lymphedema from forming. And so that's really the focus of what I'd like to talk about today. If you think of it, going back to the lymphatics are to drain all that fluid up these pipes and eventually go back into the bloodstream. One of the options that we have is called lymphovenous bypass. And that means that instead of making the fluid go all the way up the arm, we're just going to find a detour for it and connect that lymphatic channel to a vein right in the arm. And that helps offload the fluid and hopefully will reduce swelling. As a specialty, the concept kind of came about in the 60s, but we didn't really have the equipment or the sutures or really the technology to pull it off until about 2000. In the grand scheme of things, 20 years is nothing for medicine. So this is pretty recent development. And some very talented folks in Japan and all over the US started hooking up these lymphatic channels to veins and saw that about 90% of folks felt better. All of that heaviness and discomfort and tightness really started to get better, a few months after surgery. About 60% of those folks actually saw their arm shrink. And so we're really seeing a good amount of fluid management there. The remainder of folks who don't see their arm shrink, it's just fat. I'm sorry. the unfortunate part of lymphedema is that that fluid is really inflammatory, so it's really irritating. It leaks out into the fat, and the fat grows in response to that. And so there's some fat hypertrophy that happens with lymphedema, and then it feeds back on each other. So our goal with lymphedema surgery is to get the fluid under control, and then if we need to debulk the fat later, then that can be done with things like liposuction. When I talk about lymphovenous bypass, I have to find a physical structure. I have to find that lymphatic channel in order to be able to sew it to the blood vessel. If the lymphedema has been there long enough, those pipes are working as hard as they can, and eventually they will fail, and you won't have lymphatic channels left. If there are no lymphatic channels left, I can't sew it to a vein. And so then we have to start thinking about other ways that we can treat lymphedema. One of those ways is called a vascularized lymph node transfer, or it's also been called a lymph node transplant. Essentially, I'm going to go looking somewhere else in the body to find some lymph nodes to move over into the arm. Places might be the other armpit, it might be in the groin. I personally was trained to get the lymph nodes from inside the belly. I think there's really been no evidence to show that one donor site is better than the other. It really is what works in the hands of that particular lymphedema surgeon. For me, I would hate to risk causing lymphedema in another extremity in an attempt to treat one. So that's why I go inside the abdomen and I take the lymph nodes that are right around the small bowel. And I work with the general surgeon to help me do that. And essentially we take that little packet of lymph nodes and we put it into the arm. And even though we don't exactly know all the precise mechanisms of how that works yet, you can kind of think of it as a new sponge, to soak up all that fluid. It's connected to the bloodstream, and so it just pumps it straight out into the bloodstream. That option of lymph node transplant can be done at any stage. It can be done for early lymphedema. In general, I reserve it for the later stages of lymphedema, just because it's a bigger investment of your life. And then we can talk about recovery as well. What else should we talk about? Let's see here. Why would I do one of the procedures over another? I think the lymphovenous bypasses are pretty easy recovery. They work really well for earlier stages of lymphedema. The cut is barely under the skin. There's not even a lot of pain involved. It's a come in and go home the same day sort of procedure. So I think it's a really easy one to recover from. There's not a lot of investment of time from that standpoint. I actually ask people to carry a pillow around with them for a month because it doesn't hurt enough for you to remember that there was surgery. So at least if you have the pillow, you can prop it up over that month. It really relies on having those lymphatic channels present. The lymph node transplant I reserve for the kind of later stages of lymphedema. It's a longer surgery. It can take 6 to 8 hours in the operating room, and then generally requires a 3 to 5 day hospital stay to make sure that what we call the flap, or that lymph node packet that we've transferred, is really viable and healthy. And then we let you go home, and the recovery from that is probably closer to the order of a month or even 2 months. So you got to have time out of your life to be able to devote to that care. Now, no matter what surgeries we're doing, I can't really cure lymphedema, but I am trying to lessen the burden of it on everyone's life. So maybe you don't have to go to therapy as often. Maybe if you are out and about and don't want to wear that sleeve, you don't have to. We've been doing these procedures here at Northwestern Medicine since I joined the faculty in 2018. So far we've been doing pretty well, but we don't have a huge experience yet to really quote a good success rate. That's really what I have for the treatment of lymphedema. I want to spend a few minutes talking a little bit about preventing lymphedema and what we can do to reduce the risk of lymphedema. So risk factors for lymphedema. biggest one, having to get all of those lymph nodes removed, which is a necessary evil oftentimes. Radiation therapy can also kind of wipe out any lymphatics that are remaining and can cause some scar in the armpit, and that can impede lymphatic flow. Being a little bit overweight, so BMI over 30, just increases the pressure everywhere in our system, so that can increase the risk of lymphedema. So if you add all of those things together, axillary lymph node dissection, radiation therapy, which are just, necessary evils, the risk of lymphedema can go anywhere between 30 to 50%, which is a lot. It's like 1 in 3 people, or even every other person. And so we've been thinking a lot around here about what we can do to reduce that risk. And so my friends in radiation oncology are really interested in it. I'm really interested in it. My friends in physical therapy here at Northwestern Medicine also really interested in what can we do to try to reduce the risk of developing lymphedema. Easiest thing is the second there's a sign of swelling after surgery, we get you to therapy, because sometimes we can just knock it out before it sets in. The other things that we can do, or we can be thoughtful about how we deliver the radiation field. And then the last thing we can do is, those lymphovenous bypasses we just talked about? Well, we can do it in the armpit right when you have your axillary lymph node dissection. So you got those channels going up the arm, they get to the armpit, and then we scoop out all the all the axillary lymph nodes, and now those channels have nowhere to go. So now you just have fluid leaking into the armpit. And eventually that'll all scar down if you don't do anything to it. So what we can do is just take those lymphatics that are cut and are just dying for somewhere to go and hook it straight into a vein. So that's called an immediate lymphovenous bypass or immediate lymphatic reconstruction. There's also an acronym called LYMPHA, which I honestly can't remember what that stands for, but we're hooking up the lymphatics to the veins right at the time of axillary lymph node dissection. So my, breast surgery friends will do their cancer operation, and then I will come in immediately, map out the lymphatics of the arm, see where those lymphatics have been cut, and plug them straight into the veins. The downsides of that to me are it's a couple extra hours maybe in the operating room. You're already asleep. There's no new incisions. You're going to have a drain anyway. So it doesn't really change the recovery of that particular stage operation. And it doesn't burn any bridges either. So even if we were to develop lymphedema after that, all of our options are still open to us. So I really do think it's a very minimal risk addition to your cancer operation. And so far in our kind of collective experience around the country and around the world, it's been shown to reduce the risk of lymphedema by about 1/3. So you take that risk of lymphedema that's like at 30% and you take it down to about 10%, which is honestly about the risk of lymphedema after a sentinel lymph node biopsy. And so anything that we can do to prevent lymphedema from setting in is going to be a lot easier than treating it afterwards. We got a great question, which is, can any of these things be done, in other extremities? And certainly all the same principles apply. I really enjoy this topic because I feel like it's based in physiology and mechanism. And so, certainly it can be applied if you're having your groin lymph nodes taken out, or some other kind of procedure like sarcomas that really build up scar and can cause lymphedema as well. How long after surgery and radiation does the risk of lymphedema diminish? Diagnosis of lymphedema has been one of our greatest challenges. I think the population is aware of lymphedema, but not every doctor even can recognize lymphedema when it happens. And so, when you have those signs of lymphedema and you suspect that it might be there, I would really encourage, hey, maybe I should get a lymphedema therapist referral, or could we talk about it? Is this a possibility? And the reason I bring up diagnosis is unfortunately, the average time to diagnosis from the time of mastectomy and radiation, or lumpectomy and radiation, to the diagnosis of lymphedema in the chart is 18 months. So it's a pretty long time. Some of that is because your lymphatics have been chugging along, and that's when it develops. The lymphatics have been going as strong as they can, and it just crapped out at 18 months. Some of it is it's been there since radiation, and just we couldn't recognize it and put a name to it. So there's a little bit of all of that. Average time to diagnosis is 18 months, but even 2-3 years out, the diagnosis is still possible. But certainly, it's that early period, that first year, where we're probably being the most vigilant about lymphedema. After that, the chances are lower. I think if you have a diagnosis of lymphedema or a sudden swelling many, many years later, 5 years, 10 years after, I would really look for something else going on. It would be unusual for some lymphedema to show up so late, unless it's been going on this whole time and we didn't recognize it. Let's see, what else? There were a couple of questions up there that I'm trying to read. Some of the things that make it difficult. So candidates, people who are poor candidates for surgery, unfortunately, all of these things require general anesthesia. It requires that your body is going to be able to heal and stand up to a big surgery. And so we want to make sure that, the rest of your health is good. The other thing, because this is a physiologic system, if you imagine water runs downhill, everything is built on a pressure gradient. And so it has to go from the lymphatic system to the venous system. And so if there's any kind of condition that increases the pressure within the veins, this procedure isn't going to work really well. None of the procedures are going to work really well if there's increased pressure in the veins. So that means things like blood clots in the veins. It also means things like morbid obesity. We just know that the success rate is better when the BMI is less than 35 and even less than 30. That being said, I don't have a strict cutoff. I just want to optimize folks for success. If there's a possibility of getting the weight down, then the surgery is going to work better. And so I'm going to wait until I have the best chance of success for that surgery so we don't burn those bridges. There are a handful of surgeons around the country that do perform this surgery. Here at Northwestern, it's me, just me. But it is, because it is only about 20 years old in the specialty, it's just starting to move its way through our training programs. And so, there's definitely a group of pioneers of my mentors that led the way into establishing this as a real field of microsurgery and plastic surgery. And, this wave of my generation of surgeons that have graduated in the past 5 to 10 years, are going to be the folks that are going to be able to provide this service. Most surgeons that perform the surgery have done a microsurgery fellowship. So at this time, we can offer it at Northwestern Memorial Hospital in the central region. And then, there's always, I'm not the only person in the world who can do this, but Chicago is blessed with a number of lymphedema surgeons. All right, let's see what else we got coming in here. Can any of the 3 surgeries that you described be used in conjunction with other cancer surgeries to help or prevent lymphedema? Yes. Again, these also work well for a lot of our gynecologic cancers and sarcoma procedures as well. Talked about reasons why I would not be a candidate. One really difficult topic is lower extremity lymphedema that is not related to cancer. So the 2 most common causes of lymphedema have to be cancer and obesity. And it is unfortunate I don't have a good solution for obesity-related lymphedema. And sometimes it is obesity-related lymphedema that happens while the weight is still on and there's that extra pressure on the veins and it just backs up into the lymphatic system. Best option is to get that pressure off by whatever dietary, lifestyle, or even bariatric surgery options there are to get that weight off. Even after weight loss, though, that lymphedema can persist. It can just be it has already set in. And oftentimes the only thing I have to offer at that point is to debulk it with things like liposuction or direct excision. But that is a very difficult one. Let's see what else. Is there any hope or help for patients already done with mastectomy and reconstruction? There is. Everything depends on how long the lymphedema has been there and the status of those lymphatic channels. One thing I didn't talk about is how we figure it out. And so it's actually a pretty easy way to figure it out. There's something called an ICG, or Endosynine Green lymphangiogram, or mapping out the lymphatic channels. This is a procedure that can be done in our office. A couple of dots of green dye that are injected between the fingers and then a couple of spots on the wrist. So 4 total injections. And we use a fancy fluorescence camera that does not involve radiation. I like to joke and say it's like a really fancy blacklight from the 70s. It just makes those green dots glow. And it takes about an hour to 2 hours, just really boring in the office. And we take a few pictures over, that period of time. And we can see that green dye get absorbed by the lymphatic fluid and then transported up the arm or the leg. And that gives us a sense of, if we see these little squiggly lines that go up the arm, those are intact superficial lymphatic channels. And if we see a big whiteout of just fluid sitting in the arm, honestly, it's going to be no surprise to you, because you'll be like, yep, that's where I feel the swelling. That's, it correlates well to where I feel that discomfort. And sometimes just that confirmation of knowing you're not crazy is really nice, because, you look at it, like, it doesn't look that big, but you can feel it. You can feel the fluid in your arm, and you know that it's real. So being able to visualize that with the test is also, in an odd way, can be comforting to know you're not nuts and you're not alone. So once you have that, test and you can really tell if there's lymphatic channels in place, that will tell you if you're a candidate to have any of these lymphatic procedures. The only one that you can't have, having already completed all of that, is the prophylactic or immediate reconstruction in the armpit. Once that scar sets in, it's very difficult to find any of those channels up there. If there are still more reconstructive surgeries to go, I know reconstruction can be a really long process with several surgeries, big or small, and certainly lymphatic reconstruction can be done through any of those times. Let's see, what other questions have we had come in?
Someone just asked, for those who have already gone through surgery and radiation, is this still an option covered by insurance?
Yes. So you know what? Insurance companies have been really good to breast cancer patients. You have to at least give them credit for that. Every insurance plan and company is different. We always submit for prior authorization for all of these procedures. It used to be that the insurance companies would come back and say that it is experimental, and every so often we still get those, denials. But as we kind of build up our collective experience, there's a lot of really good data out there that these physiologic procedures work, and so we're having more luck with getting them covered by insurance. Anything related to the breast cancer diagnosis is often covered as part of that care.
Yes, I think the only other last question was, and this is a little bit unrelated, is have you noticed anyone coming into your practice who has had lymph nodes swelling as a result of the COVID vaccine?
You know, I got that question earlier today. I have heard of it. I do not know, however, what the implication is for developing lymphedema. You know, the lymph nodes are there to as part of our immune system, and so it may be a sign the COVID vaccine is working. Not an expert in that area, but you know, in regards to this talk, whether or not it means anything to kind of the permanent onset of lymphedema, I would imagine that it would not be related to that.
We just got another one.
COVID vaccine near my. Yeah, I have to say I'm not an expert on the COVID vaccine. I think you know, inflammation anywhere is pretty common. You know, lymphedema is, we talk a lot about the extremity, but it can also affect like the chest wall and the back. And so, you know, all of those things can be treated in a similar manner. It is just a lot less straightforward when you get out of the extremity. I don't know that answered the question, but.
Yeah, I think one last question. Did you see that one? The 4 to 5 years post lumpectomy radiation that's where she was at? Could
Yeah.
Such as carpal tunnel surgery bring on lymphedema?
I don't think so. You know, carpal tunnel is actually a very, very common condition, and the things that I worry about are big incisions that go perpendicular to the arm. I honestly don't even worry about blood draws and IVs for folks who do not yet have lymphedema. Obviously, if there is, if you got a lot of risk factors for it, you know, like radiation and axillary lymph node dissection, please try to have them, you know, use the other arm, except in emergencies. But I think some of these smaller things do not, you know, they're not going to push anyone over the edge to having lymphedema.
Another really great question
Yeah.
just came in. Yes, if we have an upcoming surgery after chemo, how do we inquire about these options during surgery?
Mm-hmm. I think it's always good to get a consult. You know, get a personal one-on-one consultation about where you are in treatment, what sort of symptoms you may have now or don't have now, whether or not we need to, you know, get you hooked up with lymphedema therapists so that you're really optimized from all standpoints. You know, some of the shorter surgeries can be done in conjunction with the lymphatic surgeries. They don't have to be. It's just nice to sometimes coordinate that anesthetic. But yeah, I think it's always just good to get that one-on-one consultation to see where folks are at.
That's it.
Excellent. Well, thank you so much for joining me today. I hope you all learned something.